was a couple of very interesting talks that I think well represented all the many aspects that we can investigate with one single equipment, and that can serve very different situations in chronic liver disease. It was shown that we can really, if patients can sufficiently be well investigated due to the absence of intervening gas, we can do really a thorough investigation of all the aspects of chronic liver disease with ultrasonography. So there are a few questions from Dr. Antonio Mashotra. So we can start with a discussion. One question is, this is something that is related to the reliability of elastography to quantify fibrosis. So when we have to pay attention. So the question is whether high stiffness values in the liver do always represent fibrosis, or it can be due to inflammation without fibrosis or other causes, just for instance, chronic heart failure. And if this is true, that they might overestimate the values, is there any possibility to distinguish the different causes? How do you work in clinical practice? So if a patient comes and has this situation, I add the question, I try to integrate it. Shall we refuse to do elastography, or we interpret the results, put in some clinical knowledge, and how we consider these values? Alina, would you start, as this question was related mainly to the elastography question, the elastography issue that you illustrated?
Yes, of course. Thank you for the question. It's a very good question. And yes, there are confounding factors that can influence. And actually, we measure the stiffness of the liver. We do not measure the fibrosis. And the stiffness is influenced also by inflammation. And this is why it should be avoided, or you should pay attention, because you can have unreliable measurements whenever you have heart failure. If you have also biliary obstruction, and you should avoid, or you should pay attention if you have high values of transaminases. More than 3 times normal, this means that your results can be influenced by the presence of the cytolysis. It depends what is the question. If you want to rule out liver cirrhosis, for example, and all these confounding factors actually is going to give you higher results. If you get normal results as elastography, probably you can rule out liver cirrhosis. I don't know if I was clear. So if you get normal values of liver fibrosis in such a patient, you can rule out liver cirrhosis, because this means that your values are lower as compared to what you have get. But you cannot give the patient an answer regarding the estimation of the fibrosis in such a patient where you have confounding factors.
So thank you, Alina. I think it was clear. So if there are normal values, these are reliable, because the risk is only of overestimation, but not of underestimation. I have, I don't know whether you would like to touch other situations where you might have overestimation, because you mentioned inflammation that is identified as a proxy by elevated transaminases, at least more than 3 times the upper normal values. And in which other conditions do you suggest that that might be a situation of false positive results in case of judgment of fibrosis? One that was mentioned is chronic heart failure in any case, or only some situations. What is your experience, and would you like to add other potential conditions of overestimation?
Me?
Yes,
Sorry.
yes, Tina, if you would like to.
Actually,
more.
It's pretty difficult when you have a patient with heart failure. Actually, if the patient is compensated, so it's well treated for the heart failure, you can have reliable measurements. But if you can see some of these patients ultrasound that they are not compensated, because if you have also enlarged suprahepatic veins, for example, this means that probably your patient is not well compensated. Of course, anamnesis is also helpful, and there I would avoid to give a result or to give a direct, I don't know, a final decision if the patient has fibrosis or not. The other situation where you should avoid is biliary obstruction, because also there you are going to have the results are going to be changed by the presence of the inflammation and the presence of the bile, second to the biliary obstruction.
Okay, thank you. I only would like maybe to add another condition which is quite rare, but is amyloidosis, systemic amyloidosis, because amyloidotic infiltration of the liver tend to create very high stiffness values. So if you have a suspicion of amyloidosis, which is also a contraindication to liver biopsy, at least percutaneous liver biopsy, transcutaneous, also in this case, there is a risk of false positive. I would like also to remark that in case of acute, not chronic cardiac failure, you can see even a rapid decrease of stiffness when you treat with diuretics. So the suggestion is to delay the evaluation if there is an acute on chronic decompensation, cardiac decompensation, whereas if the patient has chronic cardiac decompensation, you should do as Professor Popescu mentioned, assess the hepatic veins, the vena cava, and if there are signs of right heart side enlargement, of increase of right cardiac pressure, then you might have a risk of overestimation. There is a second question. Does it always exist a correlation between abnormality of liver function test? I would suggest mainly of transaminases and gamma GT, and grade of steatosis, grade of inflammation, grade of fibrosis. So if you have normal liver test, can we rule out there is a high grade steatosis, inflammation, or fibrosis? Do we need, in these cases, if there are, I would like to integrate the question. If you have normal liver function test, is it really worth, nonetheless, to perform the multiparametric assessment that you showed to quantify steatosis, to quantify the stiffness, if the transaminases are normal?
Yes, you should, because you can have severe steatosis with normal liver tests, and you can have also liver cirrhosis with normal liver tests. So the normal liver test does not rule out steatosis, does not rule out liver cirrhosis. And yes, there is a correlation, is not a strong one, but there is between inflammation and the elevated liver function tests. So you should suspect that you have inflammation whenever you have cytolysis. Unfortunately, we do not have yet an ultrasound feature for evaluating inflammation, but maybe in the future.
Mm-hmm. Okay, maybe if we can add, because the next question is about, I skipped some, I will go to the most relevant, unless, maybe Annalisa, is there any imaging modality to distinguish between alcoholic fatty liver and non-alcoholic fatty liver, or we should rely only on clinical informations?
That's a very good point. It depends on which setting, I would say. So in the chronic setting, unfortunately, I really think we cannot really distinguish between one and the other. In the setting of suspected alcoholic hepatitis, then it has been proven recently that seeing a large amount of steatosis with even sometimes reversal of portal venous flow due to the very high resistance in the right setting could be sufficient to prove this, the alcoholic cause of the acute severe decompensation and could spare some biopsy in the right setting. So unfortunately, I think we are not there to have a sensitive method to differentiate between the two. But as usual, multi-parametric correct ultrasound examination adds to our clinical skills in the right setting. Yeah.
Annalisa, as you have the word, I put to you two additional questions related to B-flow. One is by our friend Jordan Genov, and he asked whether the use of B-flow before interventional procedures, this means before putting a needle inside the liver, might help to detect intervening small vessels that could be better avoided because you know where they are. And okay, if you can answer this, do you think the B-flow is satisfactory?
I think it's personally, I think that this technique adds a lot sensitivity to your methods, so to the remaining Doppler techniques. So I would guess that yes, it would be better to use it if you have it available. It is very good for identifying tiny vessels that could, however, create some problems. So I would suggest to use it, even if I cannot prove with data that there is a difference between a standard and a B-flow based image.
Annalisa, you also showed us the use of B-flow during TIPS procedures. We all know that you are an expert in this field. You learned and you grow up scientifically in Barcelona, which is one of the centers where TIPS is most used, and there has been a lot of research about it. So the question is, you have a lot of experience in assessing TIPS. How do you assess them now? Do you use only B-flow? You perform Doppler, and you perform Doppler. Do you always perform flowmetry in all, at least 3 different positions of the tips, the initial, middle, and distal part, or one is enough? How do you assess at present with the new technique the patency of the tips?
Usually I always start with the standard, which is assessing at least the velocity in the main trunk of the extrahepatic portal vein. And I would like to remember to all of you that this is the most sensitive tool. So if you see portal vein velocity decreasing over time and decreasing below a threshold of, let's say, 26, 28 centimeters per second, that is in the different setting really described, then you should suspect a TIPS dysfunction, because you have to think that the resistance through the TIPS is increasing again, and this is what slows the flow. The second important tool that you should use is looking at the direction of flow in the intrahepatic branches of the portal vein. Usually in a standard TIPS, which is patent, this flow is reversed because it goes into the direction of the open TIPS, which has a low resistance. So if then over the follow-up, it turns again in the direction of the pre-TIPS, which is usually hepatopetal, so that's a sign of probable TIPS dysfunction. And the third sign is the intrastent velocity. And usually I use 1 point, not 3 points, because anatomically it's extremely challenging to measure, for instance, velocity in the cranial part of the TIPS. It is normal, in particular now with obese patients, very far away from the point where you measure, and you usually do not get perfect measurements. And I think really for the assessment of the stent is where B-flow can help in addition to the standard techniques, because you can identify, as I showed you, because that's a real case, even tiny restenosis, which is neointimal growth, and then you can sort of reinforce your suspicion, which has always to take into account all the other measurements.
So we can conclude with 2 final questions to Alina. One is about this is more a clinical question than an ultrasonography question. So obviously we cannot talk about too long about clinical situations, but when you combine clinical assessment and ultrasound investigation, would you recommend similar protocols and lab protocols for obese patients to assess liver steatosis and liver function as you do with lean patients? Or you change, for instance, MRI for some patients, ultrasound from others? and maybe you can combine with the second question that I put in, because there was a question about the cutoff values for this. So maybe you can integrate with this. In case of severe steatosis, do you use the same cutoff values, or there is a risk of overestimation of also the stiffness? Because this was demonstrated for transient elastography. Have you enough information with the G technology to state whether there is a risk of overestimation of stiffness in case of obesity? So this might point to different assessment in lean patients and in obese subjects. So if you can conclude by stating how you assess these patients and about the thresholds that you utilize with the technique that you mentioned, because I assume that we cannot utilize, as we demonstrated in the past, the same threshold that were provided and proven with transient elastography with all other techniques. Alina, if you would like to comment on these topics to conclude the webinar of today.
Yes, thank you. These are very important questions. And actually, we always start the evaluation of patients with steatosis using ultrasound-based techniques. And depending on how confident we are that we have reliable measurements, we get the measurements, the difficulty of getting the measurements, we stay only with this non-invasive procedure, or we go further with other investigation. We do not do routinely MRI evaluation of the patients actually in our center. We would like to perform more liver biopsies in these patients, but unfortunately, I don't know which is your experience, but it's a little bit more difficult to convince these patients that they need a biopsy. And sometimes you have to talk a lot. And actually, we base our suspicion also on the non-invasive procedure, ultrasound-based non-invasive procedure, to go further for an evaluation, an invasive evaluation by liver biopsy. Regarding the cutoff, sorry.
Exactly. Yes.
Regarding the cutoff values, I think it's important, the paper that was published, the consensus published by the Radiology Society, where for the clinical practice, they suggested a very easy algorithm. The rule of 4 for shear wave elastography and the rule of 5 for transient elastography. Where you do not have a specific cutoff value like I showed you in the research, where we looked for specific data, more an evaluation or a rule to know if you can rule in or rule out. You can rule out severe steatosis or rule in liver cirrhosis, or you can be confident that the patient has a normal liver. And this is what I recommend actually for clinical practice, because it's very easy to remember. You start from 5, and less than 5 kilopascals means that it's highly probability to have a normal liver. If you have, and the rule of 4 says that 9 is the next cutoff value, less than 9, you can rule out compensated advanced chronic liver disease. Between 9 and 13, you need more tests because it's suggestive for a compensated advanced chronic liver disease, while a value more than 13 rules in compensated advanced chronic liver disease. And more than 17 is suggested for clinical significant portal hypertension. It's very easy to remember. And it's of course, you cannot do research using this, but for clinical practice, I think it's very practical.
And in your opinion, these thresholds work well also with the QeA equipment?
Yes, they were also suggested for GE, like for shear wave elastography, for all techniques that use RFI as the basic technique. Regarding the question about the information about these techniques, they are the more recent that appeared on the market. So we don't have extensive research. So we still look for, I think there is still place to have larger studies in order to assess better and to know. But for now, in clinical practice, this is what I would recommend.
Thank you. I agree that for when the levels are low, below 5, whatever the equipment, it suggests there is no advanced liver fibrosis. Then when the levels are higher, I would pay more attention to which equipment we are utilizing, about the potential confounding factors. And this is also why we usually, as you mentioned, we do not perform biopsy in fatty liver disease, at least in Bologna, if the stiffness is normal, because there is no therapeutical decision to be taken. Whereas if the stiffness is intermediate, then it is worth to take a biopsy. If stiffness is very high, unless there are other suspicion, we already have a diagnosis of cirrhosis, so there is no need for staging. We might take the biopsy only if the etiology is very important. Otherwise, we reserve biopsy only for the intermediate stiffness stage. Annalisa, if you'd like to have any other comments before going to the conclusion.
No, thank you very much. I think this webinar was, for me, a very nice example of how much information you can get out from modern ultrasound. And I think this is fundamental for modern clinicians. We should embed ultrasound in our clinical practice to expand our capacity of helping our patients. So this is a motivation for young people to learn ultrasound.
Thank you very much. So I greet everybody from Bologna. I am from the University of Bologna. This is not a background taken from internet, but is the seat of the Bolognese Society of Medical Sciences. So I'm happy that this is a true picture that I took where we have meetings. And I'm very honored of my town, my university, and Annalisa was grown up in Bologna. She's from Bologna even more than myself. So probably she knows very well the place. I wish you, all of you, nice time, evening, or whatever it is in your place, and hope to meet you in person in future meetings whenever this will become possible, since this will mean that we have ended this bad time of pandemics. Thank you for staying with us till now. Bye-bye. Have a good time.
Bye. Thank you. Bye.
Bye. Thank you.